Hello, good morning, everybody. Welcome this morning to our live webinar entitled Crisis Preparedness, Malignant Hyperthermia and its Aftermath. It's organized by the College of Anesthesiologists Singapore and the Singapore Society of Anesthesiologists. I am Teo Lee Ming, and I'm hosting this webinar in my capacity as Head Department of Anesthesiology, Sengkang General Hospital. Before we begin, some housekeeping rules, which was previously already shown. So all participants, as they enter the webinar, will be muted to allow the speakers to present without interruption. And preferably, if you have any questions, please post them in the Q&A section. And please note that this webinar will be recorded. And if you have put in your name and your MCL number or your whichever accreditation numbers, you will be accorded 1 CME point if you do attend this full webinar session. All right, let's start. So this anesthesia meeting was actually meant to be held earlier this year after Chinese New Year, but due to COVID, unfortunately, it has now morphed into a webinar form. COVID-19 has been really a spanner in the works. It has presented the whole world with a crisis. For us anesthesiologists, malignant hyperthermia is one such crisis situation that I think we don't really want to face. Unfortunately, sometime in 2018, there was a patient on the Singapore General Hospital campus who developed what we think would probably be most likely suspected malignant hyperthermia and had an unfavorable outcome. So due to ongoing legal proceedings, we are unable to share the case details. As a result of that incident, our Division of Anesthesiology, Singapore General Hospital, we looked our crisis preparedness on the whole Singapore General Hospital campus. Now, our first speaker is Dr. Leonard No. Leonard is an associate consultant in the Singapore General Hospital's Department of Anesthesiology. His clinical interests are in obstetric anesthesia and medical simulation. He's a faculty in the department's Peri-Op In-situ Simulation program, which leverages simulation as a tool to identify latent threats for patient safety at the workplace. Leonard will now give his talk on Are we ready for malignant hyperthermia? Leonard, over to you.
Thank you, Dr. Teo, for the kind introduction. I'm just going to share my screen now. Okay. Okay, good morning, everybody. So, like Dr. Teo said, recently, 2 years ago, we had a case of malignant hyperthermia on the Outram campus, and we thought it was timely to actually revisit this topic as it still can happen even in Singapore. So that's overview of my talk. I'll just be, for the audience, I'll be going through what is malignant hyperthermia and how do we recognize it and also manage the crisis, and what are some of the challenges we faced when we were trying to revamp our preparedness status and what's the international guidelines on it, and what is our journey so far and the steps we have taken. So malignant hyperthermia introduction is a pharmacogenetic disorder that's actually fairly rare. It's just about 1 in 50,000, and it's actually interestingly also has an incomplete penetrance and variable expressivity. This means that not everyone with a genetic defect will exhibit malignant hyperthermia, and even in those with a gene defect, the severity of the reaction also varies. And this is due to a genetic defect in the ryanodine receptor, which is a calcium channel in the skeletal muscle cells. And most of these defects are due to the ryanodine 1 gene mutation. And because of the autosomal dominance inheritance, half of the children will be at risk of actually being susceptible to malignant hyperthermia. So the triggers we may be familiar with are all volatile inhalation agents, which are what we use every day, and also succinylcholine. So what happens at the muscle level is that at the sacroplasmic reticulum, this ryanodine receptor, when exposed to these 2 triggers, will actually develop an abnormal response and release massive amounts of calcium out, and this will cause a chain reaction of a hypermetabolic syndrome. So the manifestations, you can imagine, will be the patient's body will go into a hypermetabolic state with massive amounts of CO2 being produced, as well as tachycardia. In essence, the body goes into anaerobic respiration. And this increased oxygen demands can also lead to desaturation. Interestingly, although the name is malignant hyperthermia, the hyperthermia sign is actually a very late sign. And the other associated sign is generalized muscle rigidity due to widespread contraction of the skeletal muscles, and there's also masseter spasm as well. Some differentials will also be other hypermetabolic states such as thyroid storms, sepsis, neuroleptic malignant syndrome. And we should also be vigilant because malignant hyperthermia can also occur in the first few hours after anesthesia as well. So the complications that may occur are also masseter muscle spasm, such as after succinylcholine administered, which actually may impede airways, securing of the airway, severe metabolic acidosis, and because of the breakdown of the skeletal muscles, there's also a massive release of creatine kinase and hyperkalemia with the resultant renal failure from blockage of the renal tubules. And of course, the hyperkalemia will possibly lead to arrhythmias such as ventricular fibrillation. And in severe cases, disseminated intravascular coagulation may also result when the temperature is about 42 or 43 degrees. So the management, a brief overview on recognition of malignant hyperthermia, to declare a crisis and to call for help, and to stop the triggers immediately, such as the volatile agents, and remove the vaporizers, to put the patient on hyperventilation with at least 10 liters of fresh gas flow at 100% oxygen, and to maintain anesthesia with a total intravenous anesthesia technique. The surgery should be completed or aborted depending on the stage of the surgery. And the priority is always dantrolene delivery before any other therapies. We also should pay attention to cooling the patient down, such as through cold IV fluid infusion, as well as application of external ice packs or cooling packs, treating the attendant complications such as the hyperkalemia and the rhabdomyolysis. And we should also, in the crisis situation, increase the monitoring for such patients by inserting the arterial line, indwelling catheter to monitor the urine output, and also, of course, core temperature monitoring. If there are any arrhythmias or cardiovascular collapse, this should be treated through the ACLS algorithms. And these patients will definitely need ICU care because there's also a risk of recurrence. But we're not alone. In such a crisis, we have resources available to help us, such as activating the crash cart, the malignant hyperthermia kit, as well as it's important to activate more manpower to help to dilute the dantrolene. In our Outram campus and Sengkang General Hospital, we also have a crisis management manual that we can refer to for one-page reference to how to manage such crises. And we also have a malignant hyperthermia action cards, which help to delegate roles for quick action to be carried out by different participants of the crisis team. Later management of such patients include admission to the ICU, because there's some 25% may actually get a recurrence of the malignant hyperthermia, and to also continue managing the complications of hyperkalemia, rhabdomyolysis, and acute kidney injury. Following that, it's also important to label such patients that they are MH susceptible, and a memo should also be provided to them. Some ways we could do that is through labeling for the volatile agents or succinylcholine as drugs they are allergic to in the electronic medical records. It's also important to offer testing to the relatives because of the autosomal dominant inheritance of this condition. Testing of relatives, the gold standard is to perform in vitro muscle contracture testing. This is actually a muscle biopsy from the quadriceps muscle, and because it's a live muscle biopsy, it actually has to be done very close to the lab that performs it. So unfortunately, it's not offered in Singapore. So the nearest center will be in Australia, and such muscle is actually the muscle is removed from the quadriceps and exposed to halothane and caffeine. And a normal response would be muscle contraction to these two agents, which will be able to label such patients with MH susceptibility. DNA testing has also been described as well. However, it's not as good as it was originally hoped to be. The reason is because although there are over 80 possible mutations in the ryanodine gene, there are a lot of mutations that we do not know about. So if there's a negative result, it does not mean there is no mutation in that gene that we do not know about. In fact, the ryanodine gene is actually one of the largest genes in the human genome. So it's very hard to screen for all possible defects in the gene. And so if a negative result, the relatives still have to go through the muscle contracture test, but a positive, the positive DNA result will actually be good because it shows that they are really MH susceptible, so they do not need to go through the muscle test. So let's go through a quick case scenario. Imagine there's a 20-year-old ASA1 gentleman coming for tonsillectomy and a previous GA before. Okay, this patient still developed malignant hyperthermia. Yes, it is possible because not every exposure to the triggering agents will lead to MH episode. And we also like to know from the history whether there's any family history of deaths, complications of anesthesia, which is very unusual in this day and age. So it's important, again, not everyone with the gene defects will have MH on each exposure. This is a local experience. A 15-year-old girl was undergoing an emergency laparoscopic appendicectomy, and she was induced with a rapid sequence intubation, was given succinylcholine and desflurane. And this simple case quickly deteriorated into this state. The patient had developed trismus. Fortunately, the team was able to intubate the patient. The initial end-tidal CO2 was 50, and it rapidly increased to 60, even though there were many changes to the mini ventilation. And within 10 minutes, her temperature went up rapidly to 39 degrees and the end-tidal CO2 to 80. In fact, it's been described for MH that for every 10 minutes, the temperature can rise by 1 degree Celsius. So the team administered dantrolene and stopped the trigger and instituted hyperventilation and active cooling. And fortunately, after 25 minutes of dantrolene being given, her vitals normalized, her temperature and end-tidal CO2 approached more physiological numbers, and she was admitted to the ICU where her rhabdomyolysis was treated over the next 2 days. And a thing to note also is dantrolene is also prone to cause thrombophlebitis, so it should be given through a large bore IV. So some of the challenges I will describe as we went about revealing our preparedness on the Outram campus and as well as Sengkang General Hospital. One challenge was that Outram campus is actually a huge place where there are actually multiple institutions and multiple OT complexes where anesthesia is provided, such as the different national centers for dental care, cancer center, heart center, SNEC, and also remote locations such as interventional radiology, and of course, Sengkang General Hospital as well. So because there are so many different institutions, everyone has got their own workflow and there are also different stakeholders involved. And in a crisis, if more help needs to be called for to these locations, it also will involve time delay as well. And because there were different MH boxes, the contents were all differing from each other. Such as in one particular location, the MH box was actually stored in this orange bag inside the last drawer of the E-card. And actually there was no clear labeling that there was actually a MH kit there. So in a crisis, if you are occasionally giving anesthesia at this location, you may not even know there's an MH kit in such a location. And if you open up the box, you can also see that the layout is also hard to navigate. Of course, you can see the dantrolene, the orange powder over here, but the rest of the equipment is it's quite messy. So it'd be hard to actually access the supporting equipment in the crisis. And this is another location where the MH box, as you can see, is also different from the MH box in this location. So they all have different layouts and different configurations. So our learning points on the review was many different MH boxes, and some of the MH boxes did not have enough water to dilute, and they didn't have syringes for 50 ml syringes for dilution of dantrolene as well. and the number of dantrolene vials were also varying. There were some assumptions as well that the SGH major OT box would be the box of sort of last resort, that we will actually, in the crisis, everybody will start using their own dantrolene, and if they need some more, they will actually go to the SGH MOT box for further dantrolene. But this assumption is actually dangerous because the distances involved to travel is quite far. And as well as the MOT box actually covers 30 over OT. So if it leaves the OT complex for an hour, what if there's another malignant hyperthermia episode in the MOT complex? Furthermore, some locations did not house any insulin to actually treat hyperkalemia complications. As mentioned, there was poor signages for where the locations of the MH kits were, and locations also sometimes did not maintain sufficient cooling equipment, such as cold IV fluids, and some fridges where these were kept were actually locked out of hours. There were also no crisis manuals as an aid memoir to guide the team leaders in the steps needed to manage a malignant hyperthermia crisis. We identified that dantrolene dilution is the rate limiting step. The conventional way is actually to use a hypodermic needle and 20 ml vials of water for the dilution. I'll elaborate more. This is not an efficient method of doing so. We also explored alternative dantrolene formulations such as Rhinodex, as well as we found that there was also low malignant hyperthermia awareness and unfamiliarity with emergencies in some of these other locations. Dantrolene is actually the only antidote to MH crisis. The mortality is actually dropped to as low as 5% with early administration within the first 10 to 15 minutes, and it's only compatible to be diluted with water. So one vial contains 20 milligrams of dantrolene, and the initial dose for a 70 kilogram person is you will need 9 vials, and you need actually you need a pint of water to dilute. So that's a lot of water to be used. And if everything was being diluted to 20 ml vials of water, you can imagine that it would take a long time to dilute so many vials of water of dantrolene. So the dose is up to 10 mg per kilogram, which is a full 35 vials in 2 liters of water. And these patients actually need ICU care because dantrolene needs to be continued after the episode for the next 24 hours. The MH Associated of the USA actually recommends 36 vials should be kept in each facility where malignant hyperthermia triggers are administered. So basically anywhere that provides general anesthesia. So, and the dantrolene should be ready to be administered within 10 minutes of the onset of the crisis. They also recommend that it's actually not mandatory to maintain a MH-safe anesthesia machine, and also it's not recommended to change the machine in the crisis. About the alternative formulation of dantrolene that we explored, which is called Rhinodex. The conventional version is Dantrium, which is on the left-hand column. As you can see, for Rhinodex, it's actually 250 milligrams in 1 valve compared to 20 milligrams in 1 valve of Dantrium. So it's almost equal to 12 valves of conventional dantrolene. So the advantages of it will be essentially with 1 valve of that, you can it's equal to giving 12 vials of conventional dantrolene. And furthermore, it also needs only 5 ml of water to dilute this 1 valve. So it's a considerable time savings as well. However, there's a very big cost difference. For initial treatment dose for 70 kilo person, the cost is double at $5,500 compared to $2,500. And for a full treatment dose, for a ceiling dose is up to $16,000. So there was in the end, we did not bring it in because of this very considerable cost difference. Other equipment that the society recommends are, as mentioned, as you can see, sodium bicarb, amiodarone, or lidocaine, which are already found in the e-trolleys, drugs for managing hyperkalemia, as well as items for managing the temperature, and supporting accessories such as the syringes, indraining catheters, and facilities for blood gas analysis and blood taking. Now I'll talk about our enhanced MH preparedness. So we have actually now moved on to having prominent signages to show our MH box locations from this previous setup in the one particular location to actually clear labeling on exactly outside the locations where the MH kits and the MH machines are kept. As you can see, there's always a signages above where the MH box is. And also we have moved from this previous ad hoc setups to a very standardized and neat setup for all the possible things that we will need in the MH crisis. So this is our current malignant hyperthermia box. As you can see, on top of it, there are some signages. Actually, all the locations now have a standardized MH box. So they're all the same metal box with the same configurations for easier use in a crisis. So nobody has to wonder if you open a particular box, what are the items inside. So on the left-hand side, there's actually numbers to call for if you need more vials of dantrolene. And also on the right-hand side, there's also labeled the items of cooling items such as IV fluids and ice packs. If you flip open the box, on the inside cover, there's also a dantrolene dosage card, which I'll go on in the next slide. We wanted to have a very quick one-page reference for the dosages for different weights so that people don't have to do challenging maths in a crisis and make errors. As you can see over here, the dantrolene is kept on the left, and also there's a box for all the diluting equipment such as mini spikes and ABG syringes. So this is the dosage table over here that's found in the box. So if you can quickly roll down to like a 70 kilogram person, you can quickly see you need 9 vials and 500 ml of water. So that will give you a quick gauge of how much to prepare for such one patient. The overview of the box, there's actually a hyperkalemia kit, a box to house all the dispensing and diluting equipment, and also we also have put in 500 ml water for injection for easier dilution in a crisis compared to using 20 ml vials of water. And also housed in the same box is the 50 ml syringes as well. So we wanted to have a setup where we have mini spikes, 500 ml water, and the 550 ml syringes all in one location, such that we can dilute the dantrolene as quickly as possible. And there's also MH task cards, which I'll explain in the next slides what the usefulness of it is. So the hyperkalemia kit houses in one location all the drugs we need to initially manage the hyperkalemia complications, such as the calcium, the dextrose, and of course insulin is a fridge item, so it's also labeled where we can get the insulin. And within the box, there's also this dilution or dispensing box. So with this setup, housing everything in the same box, we actually can shave the time from 4 minutes from the conventional needle and syringe method with a 20 ml valve of water. From 4 minutes to dilute 1 valve of dantrolene, we can now achieve in about 1.5 minutes. So that's more than 50% of time shaved off. Cooling items also are also now maintained in the fridge and also clearly labeled on the fridge. And also they also labeled on the cover of the MH box and in the MH task cards. We also have a crisis manual that is prominently displayed in all our OTs, which looks like this over here. So actually it's an initiative by our department to actually house common crises such as airway toxicity, massive hemorrhage, malignant hyperthermia, to actually have a one-page reference for each condition on the steps to take for resuscitation. And these are actually site-specific, such as for different locations, such as SNEC. If you open the page, you will see the site-specific locations of the MH boxes, the intralipid. And if you go to another location, if you open that location's crisis manual, you also will show that particular location's MH box locations as well. So you flip open the page to malignant hyperthermia, you can see is in one page, will tell you quickly where to find the MH kit, as well as what are the initial steps such as hyperventilation, what are the drugs to treat the hyperkalemia, the arrhythmia, and how to institute renal protection as well. For the task cards, there's also found the MH kit. The idea is to actually distribute this to each person in the crisis, so as to quickly task allocate to every single team member. So it looks like this. They're all secured by rings. So if you lay them all out, there are quite a few cards, but basically they're clearly labeled, which For each participant, such as the OT nurses, you tell you can actually, as a team leader, break open the cards and hand out, for example, to a scrub nurse. Can you go and carry out the actions here? So she will go and lower the OT temperature, collect cold IV fluids and ice from these locations. And the locations of cold items are also all labeled in MH cards as well. And also, there's also a card for the anesthesia consultant as a quick overview of the steps that he needs to carry out, and also a card for the MO as well, for what the steps he can do as an assistant to the consultant leading the resuscitation. There's also quick actions for the surgeon to do, such as helping in cooling, catheterization, assisting in dilution, and also for the anesthesia nurse as well for things that she can do, such as eye line preparation, setting up for TIVA. And the deck of task cards is a nice overview, which you can see over here, that tells quickly a bird's eye view what each person job scope is in the crisis. So lastly, I'd like to talk about our in-situ simulation. I think the beauty of an in-situ simulation is actually for this rarely seen high-stakes condition, where you need to build up some institutional memory on the processes to manage these rarely seen conditions. So as you can see over here, we have practice over here is our National Heart Center. We actually practice scenarios such as the patients undergoing operation and intra-op, they suddenly develop malignant hyperthermia, and the response time to activate the MH kit. And we actually practice as a team together how to dilute the dantrolene and lead the resuscitation. So you can see here, we have one of our EU nurses very confidently using the mini spike and the 50 ml syringe to quickly dilute the dantrolene. And the beauty also of in-situ simulation is that it's conducted in the actual workplace, not in the simulation lab. So we actually use our real world native resources, such as the real tables, the real OT environment, to actually practice resuscitation in confined spaces, and also to test whether there are any latent systemic threats, such as you never know until you run the simulation that sometimes things that you expect to be readily available are actually found not to be so. So as over here you can see, we also have practice in the IR environment, which as you can see is a very different cramped, confined environment to an OT environment as well. So what we learn from crisis resource management is not just about having all this a nice MH box and all this equipment around, but it's also about the soft skills as well. So we also learn to practice closed loop communication, such as when a team member receives an instruction from the team leader, they practice acknowledging the instruction, as well as after carrying instruction, they report back to the team leader, so that the loop is closed and the team leader always has a big picture of what are the things that have been done so far. And also task allocation as well is also train team leaders to actually learn how to delegate tasks clearly, and actually the MH cards help in this aspect for a team leader to quickly delegate to roles to actually reduce the cognitive load on the team leader. And as mentioned, the latent threats for simulation, we are able to identify systemic problems. For example, through doing simulation, we found that there was no insulin, there was not enough cooling packs, or the E-card was in a very inaccessible location for some areas. So in summary, triggers of malignant hyperthermia include all volatile anesthetic agents and succinylcholine. The signs of MH are variable. In fact, it's been also called a great clinical mimicker, because signs are non-specific, such as tachycardia, as well as desaturation. The temperature change is a very late sign, and we should strive to give dantrolene within 10 minutes of the crisis onset for best outcomes. It's also possible to get MH recurrence, so this patient needs to be monitored closely in the ICU and continue to have dantrolene. And the previous uneventful GA is still possible to have malignant hyperthermia on the 3rd, 4th, or 5th GA exposure. Dantrolene is always the priority over things like cooling the patient, and we should always get as many people as we can to dilute the drug. And please use the mini spike IV dispensing pins, not needles, to dilute the requisite 60 ml of water, as it really saves a lot of time. And also to standardize the malignant hyperthermia boxes as well, and so that the layouts are similar and they house the necessary 36 vials of dantrolene. We also found it useful to put in the 500 ml bottles of water rather than 20 ml of water, because it's just too cumbersome to draw so many vials of water just to dilute 9 vials of dantrolene. Other resources that we have also developed the crisis manual and task cards as aid memoirs, and also as tools to aid in role delegation and task distribution in a crisis, as well as to practice simulation in our workplace to identify latent threats to be rectified. So, although malignant hyperthermia is considered rare, but actually, as mentioned 2 years ago, we had one case, and in fact, I also believe KK Hospital also had a case in the last 2 years as well. So it's important to know that it's the distribution of malignant hyperthermia is 2 peaks. One peak is in children and one peak is in young adults. So if a good setup to support resuscitation, I believe we can achieve good outcomes for such patients. Thank you very much for your attention.
Leonard, thank you for that very detailed lecture. And for those who have just joined us, there will be a Q&A session at the end of the presentation. You may send your questions via the Q&A option at the bottom of the screen. And those of us who are a bit confused as to why we're mentioning Singapore General Hospital and Sengkang General Hospital in the same breath, we are all actually faculty in Division of Anesthesiology, Singapore General Hospital, and we provide anesthesiology care to both campuses on the Singapore General Hospital as well as for Sengkang General Hospital. Back to our talk. So when an adverse event occurs to our patients, this has to be communicated to the patient and their loved one as well. So this morning, we are honored to have Ms. Cecilia Pang, Chief Communications Officer of Sengkang General Hospital, to provide us with insights as to how to break bad news. Cecilia oversees corporate communications, patient experience, community engagement, and fundraising in Sengkang. Cecilia has more than 30 years of experience in corporate reputation management, public relations, and marketing communications, of which the past 10 years has been spent in public health care. Before she joined public health care, she spent 20 years as a senior management experience with tech companies like Hewlett-Packard as well as Oracle. Cecilia, I hand the mic over to you.
Thank you, Li Ming. Let me try to share my slides. Just get a confirmation that you can see the slides.
Yes, Cecilia, we can see your slides.
Great, thank you. So good morning, everyone, and thank you, Li Ming, for inviting me to share my experiences at this conference. Honestly, you know, delivering bad news is really one of the most difficult aspects of communication. And there's really no subject matter expert on this, because when you're dealing with bad news, there's really no perfect way to deliver a message. So what I'm sharing a lot today is a reflection of having been placed in the shoes of someone who had to be on the receiving end of bad news when one of my family members passed away suddenly a few years ago. So it's a reflection of what I had to go through, and also based on what family members and patients tell us when I deal with patient experience, when they have to go through a similar experience. It is also not a pleasant experience for the one who has to deliver the news, so it can be totally awkward and uncomfortable, and you yourself could be equally traumatized, but I will leave City to cover, you know, that aspect of it, right? So this sharing is not going to give you all the magical answers, but hopefully to give a broad context of what to bear in mind when you have to deal with such a situation. So what is bad news? two big buckets here. One is poor prognosis, which can be anything from, telling you that you are going to lose something, whether it is a function or a body part, and all having to deal with a treatment that's going to really drastically change your life. And of course, there is death. Death can be expected or unexpected, but in most situations, it's always not totally accepted. Okay, so how do we, deal with this? But before we go on to how to deal with it, let's try to understand what's really going on in the minds of the recipients of bad news. There are some practical things that will come in immediately, perhaps, I'm going to lose something. How am I going to deal with finances? How am I going to pay for cost of treatment, etc.? Then there are all the soft aspects as well. The G words here are sometimes guilt, right? And often, what's the other G word? I'll come back to that. So it's basically having to deal with the depression, the anxiety, and all that. But really, for the first few minutes of the breaking of bad news, is none of the above. The mind actually goes into a blank. It's in computer language, you can say it has hung. In Zoom language, it is perhaps frozen, because it is a shock to the system and the mind cannot perhaps deal with it. And this is really talking from my own personal experience as well. So if it is a blank, and if you remember that this is the stage that people are dealing with right now, then you can begin to think about what you need to do next, right? So remember what state they are in. Not a good state, it's blank, they are kind of frozen. So what do you have to do next? And so the big question is how to start that conversation. I think the first and foremost, take a pause and move them to a right setting. A crowded room is never the best place to deliver bad news. Bring them to somewhere where they can be a little bit more private. And then be ready to empathize. And I will talk a little bit more about this in a couple of minutes. And the last is ask them if they know what is the present indication. So some examples of questions that you could ask. If it is somebody you are talking to a family member, what do you know so far about the condition of your loved one? Give them a sense of preparation. Or are you aware that when your loved one came to the hospital, it was like this? So, as I said, it gives them a sense of preparation for the news. So, what is empathy? Empathy, it says here, is the door that opens your voice to the information that you want to communicate. When we are trying to deliver bad news, it's not just about the content of what you have to say. It is really in the voice and the caring that you're actually showing. So it's as much your actions as well as your words, the way you say something, right? And if you don't have that, it says here, you have really lost your audience. Then something, everything else doesn't matter. So empathy, we all know is trying to put yourself into the other person's shoes. But how to do that, right? How do I know what they're going to feel? And I think it's not rocket science, it's somewhat common sense. It's try to respectfully imagine what their life may be like or be affected by the news. And if you think about that, then you will be able to adopt the right tone. It should be quite natural, but you have to first imagine, wow, if I'm on the other side, how am I going to receive this? It's also about not making judgments when they react with anger or denial or fear. We are involved with the case, but they are the ones who are totally affected. So, this anger, denial, or fear can be expressed in many ways. In the best circumstance, they may say you didn't do enough. In the worst circumstance, they may blame you for letting it happen. And so what do we do? Do we kind of react to that? Again, it has to do a lot with a pause. and thinking about, hey, you know, if I were in that position, I might feel exactly the same way. So we give a lot of leeway for them to express their denial and their anger, and just be there. There are no good words sometimes to say these things. So just let them vent, let them be angry, let them be frustrated, let them take it out on you for a while, and then after that you get the tips on how to deal with your own emotions from City here. So basically what we want to achieve is the readiness of the patient or family to receive the news, that they can understand what you're trying to tell them, reduce the emotional impact, and come to a level of acceptance. So the soft skills that you have to bring into the breaking of bad news, number one is your presence and be prepared to listen. You know, when I had to deal with this, I was rather unhappy that the doctor seems to just want to give me the bad news and run away. So are you going to stay there for a moment longer and, you know, listen to what they have to express? You definitely have to slow down your speech, because remember, the mind is a blank. They are not processing. And you have to keep a low and calm tone of voice to convey the caring. It's different to say, I'm sorry, to really say, look, I'm really sorry, to convey that caring. Show kindness through your words of reassurance and be available for them. So it's really the acceptance. How you're going to get them to acceptance is to give them respect, let them vent their anger, give them space, and give them time. So what is the right setting? I mentioned earlier, don't break the news in an open environment. In an ICU situation, for example, it's kind of hard to find a quiet corner, but take a minute to look around and find that corner before you break the news. Also, don't assume that everybody around that person are the NOKs. You could have two families within that same area, and they are listening to, you know, what you have to say. Last of all, don't look like in a hurry. Don't say you have another person to attend to, so I'm sorry, I just have to tell you this news and, you know, I have to go. So the right things to do, of course, is to find a room, private spot, find out if all the close relatives are already there. Repeat again, slow down your speech, ask them to take a seat if possible, have things like tissues, water available, and give them time to digest. I think this is really important, because if the mind is blank, give them time to get through the information, offer to come back. Is that, you know, let me give you a few minutes, you know, to think about this. I will be back in 5 minutes to talk to you. So these are things that patients have told us about what doctors said. You know, one doctor told them, you understand now, I don't want to paint a very nice picture for you. Yeah, and then to the doctor, he's just telling what is real. Or when we informed him that my mother-in-law was in pain, he remarked, nobody dies of pain. That is rather insensitive. So we have to watch what we say. But I also want to share the times when we have done it right. So this one patient told us, she wrote into today to give us a compliment. He said the doctor, when he came to tell me my pathology result, crouched down to the same level as me. I can imagine how uncomfortable that position he was, but he was in, but he had better engagement with the patient. And she told me the words that gave her the most encouragement was, don't worry, I will be here with you all the way. So try not to be blunt. All these are real statements and phrases that doctors have used. You have a very bad tumor, and unless you go for surgery, you are going to die. Can we rephrase that? And try not to use jargon. Or even when they are giving you time, don't say things like, take time to think through this, you won't die from this tomorrow. Better phrasing, unfortunately, I have some bad news to tell you, but let me assure you, I will help you through this. It's the same as what the patient told us earlier. The reassuring words were, I will be here with you. Don't use jargons, say simple language, because already they're not processing, so whatever you tell them, they cannot understand. And then when you say, take time to think this through, I know this is not the news you want to hear, you know, I will give you some time now, okay, take 10 minutes and I will come back and talk to you again. And do come back. Poor phrasing are things like, there's nothing more we can do. You say, well, it's the truth, right? Or things like, I'm sorry your father has expired. And you can say, what's wrong with that? But expiry sounds like, you know, you're not products on the shelf, you have an expiry date, right? So better phrasing, so sorry about your loss. Pause, give them time. What can I do to help you through this? Would you like to speak with our medical social worker? Can I give you some time? Come back to answer your questions. So I hope that, you know, this kind of gives you some framework to deal with such a situation. But it's in the end not about the words, but trying to show a genuine interest in the person, because the person is a person, it's not a disease. Try to get some conversations. I see that you must be very close. Are you okay? What can I get for you? Water, whatever. This is a case in point. I just want to go down to the last line because of time. The last line says, because of the way we handle people, they felt that the medical staff lacked proper training in handling an emotional situation. So if you can, try to attend some of those courses that the patient experience team has to offer in terms of breaking bad news, dealing with conflicts, etc. So just some last tips. Focus on what you can do to help. Sometimes you can say, but there's nothing more I can do, but still that is something a little bit more that you can help to do. Even if it's just getting water, getting them to, you know, in contact with right people, etc. Converse with them, don't argue or challenge. There's no point of doing that at this time. Where there are differences, you can agree to disagree and say, I will come back to you after you have some time to think about it, okay? And it's about respect. Don't stick stubbornly to your point of view. Listen to what they have to say. All these are mindfulness values, by the way. Be curious, what is really bothering them? Give them the benefit of the doubt and do a timeout. So the conclusion is, first you must listen. Really listen. Be okay with silence even. Sometimes they're not ready to speak, but try to get some cues from their body language. And yes, watch your words. Be careful of how you say something, what you say, how you say it, the tone which you are using to convey the message. And lastly, it's also about what you didn't say, but what you did for them. So with that, I conclude my session. Thank you.
Thank you, Cecilia, for enlightening us as to how to communicate better. Make it sound very easy, but then we were all confronted with that situation. It's not going to be very easy. Next up, we have Ms. Siti Mariam. And the reason why I asked Siti to speak with us is, you know, when an adverse event actually happens to our patients, unfortunately, we may also, as healthcare providers, become the second victim. We do go through a lot of guilt, a lot of stress, and we really need some self-care in the end. So it is my pleasure to introduce our next speaker, Ms. Siti Mariam. Siti is our principal medical social worker in Sengkang General Hospital. She's a strong advocate of the Peers Actively Lending Support Program in Sengkang. And today, Siti will be giving us a talk on critical incidences, okay to be okay, and it's okay not to be okay. Siti, you're next up.
Hi everyone. Just give me a minute, let me share my slides. Can you all see my slides?
Yes, we can.
Right. Hi. Thanks, Lini. Before I start, maybe to begin with, when I chose this topic, It was very early, I think end of last year or early this year, and I didn't realize after that a Korean drama actually came up about this. It's very interesting, and I realized that there's more and more conversation about talking about that it's okay not to be okay actually. Yeah, so it's just interesting that, you know, when I chose this topic, I didn't realize how popular this phrase is going to be. Yeah, so let me start by sharing what I'll be covering. Okay, there's two aspects: when a critical incident happened, and then imagining after a critical incident. Okay, so what is a critical incident? Basically, I've taken this definition from WHO. It's an event that is out of range of normal experience. It's sudden and unexpected. And normally, there's a perception that there is a threat to life safety issues. And potentially, it will cause intense, immense emotional and physical distress. Okay, so, you know, when a critical incident happens, this is how probably our mind looks like. You know, it's just a whole big red dot covering everything. And when you think about it, we find it very difficult to know what to do next. So in crisis intervention, this is basically what we hope to be able to do. Very importantly, when we're trying to foster resilience, first of all, trying to stabilize. Secondly, is to mitigate any symptoms that may come out. And with that, hopefully, you'll be able to return to adaptive functioning. Otherwise, you may have to consider getting help. Yeah. Okay, so what happens when a critical incident happens? Normally, these are the three common responses when we are under high stress. We either go into a fight, a flight, or freeze response. Yeah. So and this has happened many times. When I supported some of my nurses who had gone through critical incident, they are very. It can be a very one. It is one incident, but their responses can be very different. So from one nurse, she became very angry. She wanted to actually find fault, you know, and she started listing in her mind what was going wrong, right? And trying to tell the doctor, look, this is what you've done wrong. Okay. Another nurse actually told me she just froze. She just couldn't do anything. She just, in her mind, she knew what to do, but she doesn't know how to start that action. She basically just shut down. Yeah, and then there are some who actually just say, I don't want to be there. You know, I wish I can just disappear from this. They start panicking. They're not sure what to do. You know, the thing that goes through their mind is that I just don't want to be here. I don't want to be here. I don't want to be here. Yeah. So the thing is this: our responses can be very different in different situations. Maybe if I can just ask you to take this time to think of the most recent crisis that you've experienced, right? Think about what was your response then. Was it something that was in the fight mode, a flight mode, or freeze mode? Okay, now, like I said, our responses can be very different in different situations. When I reflect on myself, I realize that when there's a critical incident that's happening external to me, I'll be very fast in jumping up and running towards it. Yeah, but when it is something that involves myself, so for example, I recall when a car hit my car, I went into a freeze mode. I just didn't know what to do. Yeah, so different circumstances, it can be very different responses. And whether you like it or not, your first initial response is something that you may not be able to control. It's just biological. It's just how it is. Yeah. basically what can actually help, is to find that calmness within that storm, that hurricane, right? We know that, we know that when there is a hurricane, when there's a storm, the middle of the hurricane is where is the calmness. And that's where we are trying to be when everything is happening so fast, right? So this is one of the mindfulness technique, which is STOP, stop. If you find that you are in that kind of mode, first of all, just stop whatever you are doing. Just take a few deep breaths. Yeah. If you find it very hard to focus on your deep breath, you can just do three counts to an in breath, and then pause for 4 counts, and then 4 counts out breath. Okay, take a few of these deep breaths, and then just stop and observe what's your emotions, right? And then after that, proceed. Okay, what does this, this does is to actually give you a pause to actually figure out, will you be reacting or will you be responding? Yeah. So if you find that you are really not able to function, just do this STOP for a short while. Yeah. It only takes less than maybe half a minute to do this. Okay. So once you've been able to function again, this is the next step about what's going to happen next. Basically, I have put in the symptoms of post-traumatic stress disorder. And a lot of people like to say this whenever they refer a case to me, we need you to come down, we had traumatic incident happen, can you assess for PTSD? Actually, PTSD don't happen immediately, right? Basically, it happens, you can only be diagnosed perhaps 1 month later if there is really intense impairment to your functioning. But the symptoms that you see here on the slide is very, very common that you will, it is likely to happen within the next few days, within the next few hours even. Yeah, you may not have all these symptoms. It can be a few of this. A lot of the staff that I have supported have given me feedback that immediately after the incident, there's a lot of recurrence about of what has happened, and they keep bringing themselves back to the moment of the event, and then sometimes they see flashbacks, pictures of the incident. Sometimes it could be as if there's a video playing in their mind. It just goes on and on and on. And it is also very common for some of them to tell me that they find it very, very difficult to sleep. Even if they try not to think about it, they just cannot sleep. Or even if they are able to fall asleep, they cannot get good rest, or they wake up very frequently during the night. And I think one of the other common symptoms that they experience is hypervigilance. They become very jumpy, easily startled. They're always on, like as if they're always worried that something else is going to happen. Yeah. So a lot of them, one day after would contact me and tell me that I think I'm going crazy. This is very difficult. I think I'm not coping. And I always have to assure them that when something critical has happened like this, very traumatizing, it is very, very normal. It seems as if you're going crazy, but it's actually very, very normal to have all this, to have a lot of these symptoms. And the reason is because when an incident happens, our body goes into a mode where it's on survival mode. It is always on the lookout to make sure that it does what it can to keep the body safe, right? Your mind, the reason why your mind shuts down is because there's a threat that the body has identified, and it goes into, again, survival mode. So things about your higher functioning, like making decisions, this actually shuts down. So you just go based on very, very instinctual. You're very instinctual at that point in time. Yeah. So if you find yourself finding it very difficult to function, do a lot of deep breathing. because that's one way that has been found to actually help your body feel calm and remind yourself that you're actually now safe, and try to find ways that you can find control. Okay, so I will go on. Right now, maybe I'll just take this time to play a short game with you. If you have paper and pen, otherwise, if you have your computer with you, open up a Word document. We're going to play a word association. I'm going to flash a few words, and then just write down the first word, or maybe describe the first image that comes to mind as you see the words. Yeah. Okay, so I'll flash the first one. Doctor. 2, success. 3, failure. 4, error. 5, responsibility. All right. Can we use the chat function? Can you help me type down, for the word doctor, what were some of the words that you thought of? Okay, I can see the chat function here. Okay, I'm sorry, I can't see the chat function here. So, okay.
Siti, have you found the chat function?
Yes, I can see it now. Okay, so for doctor, some of you have written professionalism, stethoscope, busy, stress. Interesting. Hospital. Okay, how about success? Medal, teamwork, failure, happy, recovery of patient, respect. When results went well as a team, variable definition. Oh, okay, good. Thank you. How about the third word, failure? Sad, rejection, despair, a lot of sad. A little sad, disappointment, hard to accept, failure, room to improvement. Okay, how about the next word, error? Drug error, regret, fear, learn, oops, guilty, guilt, death, improvement. Mindfulness happens to all. Regrets. Okay, let's go to the last word, responsibility. Burden, stress, care. Oh, I see a few burden. Okay, duty, safety, heavy burden. Should be ingrained in us. Stress. Duty of a nurse, feeding many people. Accountability, caring and love. Okay, very interesting. What we think of ourselves define how we will actually try to cope and what we think of the situation. there's no right or wrong answer in terms of what you think of these words. Basically, these are common words you will hear when, in the work setting, right? If let's say a critical incident has happened to you, right? What are the first things that come to mind? Is the word responsibility? Is it failure or error? Or is it your role as a doctor, right? So these are things that probably will you think it will define you, but actually you all can move on from a critical incident, no matter how bad it is. Yeah, definitely. I like that some of the words that were shared are growth words, like learning, right? And we do learn from our experiences, and the body learns too. Basically, when we've encountered our first critical incident, our body learns and absorb that experience. And when the next time, hopefully it doesn't happen, but the next time it happens, it actually learns, and it can either help you or may even paralyze you, right? So like Leonard has said, going for simulation, knowing, having job cuts, all this actually will really help when you are frozen or when you want to react. This will give you a pause to then focus on what needs to happen at that point in time. Yeah. And back to the phrase of my title, for some of us, we will respond quite well, right? And that's okay, right? Sometimes people ask me like, hey, something happened to this patient. How come the staff looking after this patient didn't cry, right? So I said that, why should the staff cry? It's okay if the staff don't cry. We are all affected differently. And some people, even if they are not there, sometimes get very affected just by listening to their colleague's story. And that's okay too, because we just don't know how it will affect us. Yeah? But if we know that it is affecting us, please do take care of yourself. Like I said, taking care of yourself, doing deep breathing, trying to return to some sense of normalcy, gaining some control over what's happening, trying to feel safe again. Yeah. And it's also important to be able to talk about it, right? It is no shame to actually talk about what has happened. Yeah? So here, I like to remind you that, a critical incident is just one red dot in your life. It's not going to define you, right? Your life is bigger than just that one small red dot. Now, if you find that even after some time, and normally we are looking at between after 3 weeks to 4 weeks, you find that it is very, very difficult for you to function. You can actually contact, these are some helplines you can actually get to ask for help. Tracks from CGH, they offer support, a lot of support for medical staff. They are actually open for anybody, but they also specialize in supporting those in institutions. Counseling and Care Center is also a counseling center that you can actually go to ask for help. A lot of hospital staff I know do contact them for help, right? If you're in SingHealth, there is actually a SingHealth Staff Care Center, S2C2, there's actually a helpline. You can go into Infopedia, there's actually the number there. But in each institution, there's actually also individual helplines. NUHS also has a staff counseling helpline, so does Kutik Puat PELS. I'm not putting down their numbers here because I've not gotten permission, and I think some of them may not want this to be open for, if they're not open for all, it's basically they will support staff within their own institution, but tracks and counseling and care center are open to any staff. Okay, lastly, I'd just like to remind you, we are all like trees, and the best is to be a tree with deep roots. And to do that is, like Leonard said, have your simulations as much as possible, be prepared psychologically and cognitively about what's going to happen, be familiar with your surrounding, right? Already from now on, self-care, right? So that you have a variety of coping techniques that can help you when a crisis happens. Yeah. And if really need to, don't be afraid and don't be ashamed to actually get help, because the faster you get help for yourself, then it might be easier for the counselor to actually support you. Yeah. With that, I end my session.
Thank you, Siti, for that sharing session. And also thank you everybody for participating in the chat fund. I mean, when Siti actually asked for some audience participation, thanks for being so forthcoming. And you might have to, Siti, did you come up with the title yourself? Because if you did, you should have copyrighted it. In the Korean drama with pay royalties.
No, I didn't copyright it in time.
Okay, and we have, before we move on to Q&A, as I mentioned earlier, this webinar was supposed to be held in Sengkang earlier this year. So because you can't come to Sengkang, I mean, it's more difficult for us to actually cross institutions nowadays. We actually, if you have noticed, our backgrounds are actually have pictures of various areas of SKGH. So just some trivia here. All right, so now we will actually like to go to the Q&A session. Leonard has actually answered some of them, but I will actually read out some of the questions because I'm quite guilty of actually sometimes zooming in and driving, or I'm actually doing something else and I can't read the chats. So the first question from Dr. Gan is, what is the reason it's not recommended to change the anesthesia machine during an MH crisis? So Leonard says that this is because the priority is in controlling dilution, and in changing the machine may actually draw manpower away. Furthermore, there's the risk of cable disconnections or misconnections with the changing of a machine in a hurry. With a high fresh gas flow of more than 10 liters per minute, it has been shown that the concentration of volatile agent rapidly declines. Leonard, do you have anything else to add to that?
Hi, thanks. That's actually a good question that often comes up. So I think traditionally we always think of bringing in a fresh anesthesia machine, but it's been shown that actually just going on high fresh gas flows is actually enough to rapidly drop the volatile agent concentration. And actually, no one really knows how low must the concentration be to stop the MH episode. Furthermore, the most important thing is the dantrolene that will actually stop the calcium release from the calcium receptor. So that should always be the priority. So in a crisis as well, let's say if there's really a need to change the machine, one could actually disconnect the patient and put on the ambu bag or transport ventilator while the machine is changed in the interim. So that's one possibility.
Okay, thanks for that, Leonard. The subsequent questions, I think 2 questions are also for you. I think Belchi commented about the water for injection. Can we label the water not for direct injection? Because the concern is someone might accidentally hang up and cause lysis, like saline. Okay, I presume Belchi means that we should differentiate the water that is meant for IV injection and the water that is not meant for IV injection.
Yeah, I think that's a good point. But although I think we can definitely do that, but I think the risk is quite low because these bottles of sterile water, they actually kept locked in the MH box. So only during a crisis, there's only time that they will be like taken out of the box, and it's also kept together with the dantrolene. So and the nurses also know that they're supposed to use the mini spike and the water for injection for dilution of dantrolene. So I think it is a possibility, but unlikely that they will put it up to as a direct IV infusion.
Okay. And Recent has a question on what's the recommended minimum number of vials of dantrolene for a standalone facility away from an acute care institution.
Yeah. So that's also a good question. There's actually a consensus statement paper by the MH Association of the United States last year in anesthesia and analgesia that answered this precise question. So the recommendation for standalone facilities is still 36 valves because you need to have enough for the full treatment dose of 10 milligrams per kilogram for patients because it's a bit, understandably, it's difficult to actually evacuate the patients in a hurry or to get more dantrolene to isolated facilities.
And we have another question. Do we have activated charcoal filters in Singapore to be inserted both on the inspiratory and the expiratory port of the ventilator?
So there's also another thing that we explored, but when I worked with the nurses, it seemed that it was not a readily available product to be found, at least for the purposes of putting in our anesthesia circuits.
Okay. And actually a comment just came from Nian Chi, Prof. Nian Chi, about water for injection. He says water is used for dilution anyway. There may not be any significant effect if unintentionally infused as water. Thanks for that, Nian Chi. Okay, so I'll just follow the sequence of the Q&A questions that are coming in so I don't miss any. So I think this question is probably for Siti. Dr. Jane George has a question for you, Siti. Is attendance at counselling centre confidential?
Yes, all counselling should be confidential. Yeah, even if the ones in the hospital, normally they do not need to report to anyone that the staff has come for counselling. Yeah.
Actually, so Siti, back to those two numbers you provided for our, if we could call, because I think our whole anesthesia community is actually has two components in terms of we're actually part of the restructured hospitals or we're actually practicing in private. So are those two, the numbers that you provided, those two, like the care counselling one, right?
Yeah.
Are they 24 hours?
No, they are not. They do have their own opening hours. Yeah, so they're not a helpline where you can just contact to ask for help. These are where you need to make appointments to see the counsellor.
Oh, okay.
So for tracks from CGH, they do have a consultancy aspect of their service, where if let's say you are in private practice and you like to set up either a formal support structure with them, where if let's say something happens, you want them to come down to support the staff, or you want to get their help in terms of how to prepare staff to build resilience, how to build a structure where they can staff can support themselves, you can actually also contact tracks.
Okay, thank you. Okay. So Claire has a comment about the MH box. It has all the labels. Are the labels for the MH boxes available commercially, or is it a SGH DIY thing? And I think Leonard has responded. It's actually done by our nurses. Nurses put in quite a lot of work. They're quite obsessive about the alignment, the colors used. Yeah, they have been incredible help with actually coming out with all these boxes and making them stand out and be very obvious. Okay. Nelson has a question again. This is for, unfortunately, a lot of them are coming to you. If the alternative to dantrolene is expensive but easier to dilute, can we consider bringing them in as a country through ALPS? And is it available in Singapore? It is, right?
To my knowledge, no institution is using Rhinodex, but when I source through a pharmacy, it can be brought in from out of the country. Currently, there's no HSA, it's not a registered product as well currently, but I think it can be brought in as a special exemption product. The problem is, like Dr. Nelson has said also, it's like everybody is sort of like ordering their own individual stores of dantrolene. So it's also not easy to bring in this really used product unless we all like combine our efforts together. Then maybe the price may be able to be brought down to a lower price point. One frustration that was faced also is because although on the Outram campus, everybody is all as part of SingHealth, but everybody, institutions, for example, like National Dental Center and SNEC are all ordering the dantrolene separately. So there are different like contracts with different vendors, and their dantrolene also all expire at different rates as well. So it's not an easy process to like get them all to switch and bring in this new product as well, especially that it's more expensive as well, because their budgeting also doesn't belong directly to SingCal or SGH anesthesia department.
Yeah. Okay. We move on to the next question. There's a question about medical students taught communication skills during their undergraduate training. I believe so. Cecilia, do you have any experience about whether communications is part of our undergraduate curriculum and how well is actually, or how much time do actually the undergraduates spend doing this?
Yeah, so I've always asked this question myself to our teachers and trainers, and they assured me that communications is always covered as part of medical students' training. But it's not a very large component. And I think that as they come on board to work really within the hospital, they are shown situations, or they have to deal with situations which perhaps they have not thought was so important, when they were learning the subject in school. So I think that there's always room for us to remind, because especially in the age of digital communications today, a lot of us have forgotten how to converse really with people.
I think there is a comment that's come in. It's on the chat, I think. Let's see. Oh, as from Alina. Alina says young Lulin students have communication teaching breaking bad news, which is tackled in 4th year with simulated patients. That's great. And Yanchi says that communication is examined in the OSCE component as well as using standardized patients. Thanks, Alina and Yanchi, for that. Okay, and we go on to Li Hun's question. I think this is, I wonder who should take this. Li Hun's question is, what advice do you have for a healthcare worker who is emotionally affected by a critical incident, yet has to break bad news to next of kin? I think, Cecilia, would you like to take that?
I think, what Siti said at first, that, you first have to deal with your own emotions before you can start helping somebody else. It's like the flight thing on board the plane, where you have to put on your oxygen mask first before you give it to somebody else. So some of the tactics that she has taught, like take the deep breath, calm yourself down first before you can go and calm somebody else. So I think that is really important, and take the time to do that. Just do the stop thing, and then the last P is, after you have calmed yourself down, then you can proceed and go and talk to somebody. And therefore you apply the same kind of techniques to them, help them to calm down. Maybe Siti has more to say on this.
Yeah, so if I can add on, if let's say you find yourself in a situation where it's so difficult for you to function, you may choose perhaps to ask for help, or somebody else maybe will help break the news if you find it very, very difficult to do so. Because otherwise, I think if you are not in a calm state to break news to the next of kin, you may not then be able to be present, and therefore you will not be able to help the next of kin. Yeah, I've seen how some of the doctors, they actually go in as a team they have nurses, and sometimes I have also been called in my capacity as a medical social worker to come down and help break bad news. So we go in together. So each one has a role where the doctors will break news about what has just happened, and then I will stay on to support the family to help them with their emotions. And then also, sometimes I will also dual function, go back to the team and ask if everybody's okay, and if I find that any staff is really badly affected, we give that person a time to really sit down, to hear out the staff, and maybe if need be to refer to one of my staff counselors for further support.
Yes, and in the chat also, I think Jungo has also suggested that for our junior doctors, it's probably not good to do it alone. Difficult conversations, especially if you are you're dreading it, you might want to pull a senior colleague along, to help you with the conversation. Thanks for that, Siti. And there's a question for you, Cecilia, from Sharon Ong. Cecilia, how do you handle difficult relatives who demand continued treatment indefinitely in the hope that a miracle will happen when it's very obvious that to the physicians that it's medically futile, like in brain death?
I think, in fact, there was such a situation at KTPH when I was there. And there was a family who insisted on doing manual resuscitation, even though the doctors had advised them that it's futile and there was multiple organ failures, and maybe we should just let the patient, kind of have some peaceful moments. It was very difficult. There was no talking of reasoning with them. And I think June's answer, where she says you have to activate a senior colleague, is still relevant. And in that case, we actually brought in some of the most senior educators that we have, clinician educators that we had, who had to convince the family and to give a different perspective. So I think still some of the principles of dealing with distraught families have to apply, where you have to try your best to calm them down. And if they are really cannot, they are really not listening to you, give them the time and space, because they actually took over the manual resus from the doctors. They kind of snatched the bag over from them. And yeah, so after a while, then they will realize that really this is not going to work. So, giving them that time and space, respecting it, don't, even though it really irks you, you just have got to let them see the futility in a way, or to experience that. So it did take a long while. It is not something that you can solve with one sentence or one paragraph. It takes them time to really assimilate and to accept. So give them time for acceptance.
If I can add on as well. Yeah, so yeah, I think what Cecilia has pointed out rightly is to give family the space. I think it's a lot about pacing with family members about where they are. I think research has shown that people need to hear bad news more than one time, because the first time you deliver, a lot of things don't actually sink in. And you may have to tell them a few times in different ways for them to actually hear your message. For us in the ICU, we actually use a team approach, where we huddle first, we talk about what we need to do. And normally, if I have time as a medical social worker to build rapport with the family members to find out what is their understanding about what's happening, what are their values, what are the maybe past experiences with the medical team, with the hospital experience. All this will give us an understanding first about where they are at that point in time. Yeah, and then once you deliver the news, you have to check in about how much they understand, where they are. One strategy we tend to use is we try to find an ally within the family who may seem to be more open to be hearing you. and see if this person has influence over other family members. So we will work through this family member, in understanding about what's happening, and then see if this person is able to slowly bring the information back to the family. Yeah. I think very importantly, family members fear that the team is going to abandon their loved one, right? And that if they choose the way of stopping everything, it sounds as if they've given up, right? And we're not going to do anything for them. So there's a lot of assurance that's needed to explain to the family that even if they choose to do this, right, the team will still be there to support the family, to support the patient, to make sure as much as possible the patient do not suffer unnecessary pain. So normally that gives a little bit more comfort to the family members. And we also talk to them about finding out patients' values, whether this is what patient would have wanted, so that we all are aligned. It makes it easier when we are all aligned with patients' values and wishes.
Thanks, Siti. I think that was a very good point about finding the ally, somebody who is a little bit more open to, take on your point of view and understand where you are coming from. Yeah, so that has happened to us also several times at ED when, patients was objecting the autopsy for the patient, and then we spent many hours in there because the family members were just shouting, etc. And then we found a small opening, with one person in the family. And when you pull her aside and begin to talk to her, it took many hours because, as you said, you first have to let it sink in. Then maybe they begin to see some light and see where you're coming from, and they can help to convey the message. So thanks.
Yes, and Cecilia, Prof. Ruben has a question here regarding the KTPH case. He wants to find out what's your opinion about whether the duty or the responsibility of the doctor was to the patient or to the family?
That's always a perennial tough question for everyone. And I think that in the end, what happened was that they had to call in the ethics committee, if I recall correctly. If there's somebody from KTPH who's on the chat, you may also share if you were part of the incident. But in the end, like I said, they had to call in the ethics committee to assure the family that, what they did or what they advised not to do further was an ethical move on our part for the comfort of the patient. I think, maybe from a doctor's point of view, that we always say that our responsibility is to be the advocate for the patient.
Yes, I mean, our first priority is always to the patient, but of course, as you said, this is a bit tricky because we're all intertwined as human beings. Our families actually form a huge component of our lives as well. But I mean, just looking at Ruben's question, as an MCQ, if it's a dual choice, I would say definitely it's to the patient first and then to the family.
Yeah. Not easy situations to handle really, and it was quite traumatic for all the doctors who were involved in that case also. But having the ethics committee really helped because it gave a more objective view of the whole situation and not the ones who were directly involved with the case.
So since Ruben, if you're still there, do you want to say something? Okay, Ruben doesn't want to say anything, but he has typed thanks, agree. And Belchi has a comment here. Sometimes when in a difficult question, maybe a change in person might be useful because sometimes it's just a matter of a connection. Yeah, I think we find that quite commonly. It's like sometimes we just don't click with certain people. I mean, it's not our fault, but it's just that someone might not like our way we speak or our mannerisms. So yeah, sending someone else to deal with a difficult situation may actually get a breakthrough instead of keep hitting on the same wall all the time. Okay. I'll wait another maybe 10 seconds for any other questions to come in. Okay. All right, there's something posted by Nelson. Thank us for this talk. Thank you very much too, Nelson, for inviting us. And we also like to thank the support team from the Academy. They've been incredible. This, I think they actually, sounds like they put in more, seems like it's more work than even the live thing, all the prep that gone into this webinar. Okay. So to conclude, I just want to thank all of you for your attendance and for staying with us thus far, and for all our 3 speakers for taking the time to prepare as well to speak to us today. I hope all of you in the audience have actually taken back some tips as to how to not only manage MH, but also on aspects of communication and self-care, which in this current COVID situation is actually also quite pertinent. And we hope that you have a wonderful weekend. And for future programs, akan datang, I think the Academy and SSA has actually planned some other events in the upcoming months as well. Okay. So have a pleasant weekend, everybody.
Thank you.
Thank you.
Thank you. Bye.
Bye.